Our final speaker for this session is Dr. Jonathan Sevransky. Dr. Sevransky is a professor of medicine and director of medical ICU at the Emory University Hospital. He's also an assistant director for Emory Center for Critical Care. His presentation today is Steroids, Thiamine, Vitamin C, and Ang2 in 7 minutes in septic shock.
So I appreciate the opportunity both to speak and to end the session. In 7 minutes, I'm going to present 8 trials and 1 consensus guideline, along with a few thoughts. There's a tremendous amount of biologic plausibility for using vitamin C and, to some extent, thiamine and steroids in sepsis. Vitamin C is anti-inflammatory. It blocks some of the bad things like NF-kappa beta, and it's involved in catecholamine synthesis. In patients with sepsis and septic shock, vitamin C and thiamine levels are low, and there is some thought that thiamine might prevent some of the complications, such as the development of kidney stones. So towards that end, after an observational trial, Barry Fowler and a group of 3 centers did the Citrus ALI trial. Modest size, their primary outcome measure were things that were important to clinicians but not patients. And you can see them on your left. None of the 4 primary outcome measures were made. They looked at 46 secondary outcome measures. 43 of them did not change, but one of them, mortality, did, which is why it got into, I think, a high-impact journal. And mortality was lower in those treated with high-dose vitamin C for 4 days. That led to a number of smaller trials and the large Lovett trial that was published last year by the Canadian Critical Care Trials Group, 872 patients, proven or suspected infection. They got to them a little bit late, and that's true of all of these studies, including our own Victus trial. I'll talk about it in a moment. They had to be in the ICU for less than 24 hours, high-dose vitamin C. The comparator was placebo, and the primary outcome measure was organ-free failure days at 28. They stopped the study early because there was a 21% increased risk of hitting the primary outcome measure for those treated with vitamin C. Mortality wasn't different. So how about giving them all together? Because again, there was some biologic plausibility. 3 modest-sized trials, the vitamins trial done in Australia and New Zealand, modest doses of vitamin C, again for 96 hours. The comparator was steroids. Days that they were alive and free in vasopressors in the first 7 days was the primary outcome measure. No difference between their primary outcome measure. Similarly, in the US, Mike Danino's looked at 200 patients with septic shock and ARDS under 24 hours, modest doses of vitamin C, thiamine, and steroids every 6 hours. The comparator was placebo. No difference in the primary outcome measure. 1 of the 10 secondary outcome measures hit the target. And our Victus trial that enrolled 501 patients with confirmed or suspected infection with either respiratory or cardiovascular dysfunction, modest, the same dose of steroids, vitamin C, and thiamine, and the primary outcome measure was vasopressor and ventilator-free days, and a secondary outcome measure of mortality. No difference between the groups in either of the 2. And last month, Shaniqua Robertson from Wes Ely and Jim Jackson's long-term outcome group looked at the 6-month brain outcomes in these patients, and those that were treated with vitamin C had worse brain outcomes at 6 months. So the question that I was asked is, when should you think of using these agents in sepsis? I have one answer, or 2 answers that's informed by 1 study. If you have scurvy, you absolutely should give your patients vitamin C. And since this was probably the first clinical trial under the guise of a well-designed clinical trial, you also potentially can give vitamin C. I should mention that steroids do have a role in the treatment of septic shock, and I should mention that almost all of the data that I'm presenting has to do with septic shock rather than the more general vasodilatory shock, even though the majority of patients do have septic shock. And this is one of two systematic reviews and meta-analyses. This one was done by Bran Rochberg of the McMaster University, looking at about 9,000 patients in a large number of trials, including adrenal and approach. And for those who were given modest dose steroids, you came off the ventilator faster, you came off vasopressors faster, there was a long-term mortality effect and probably a short-term mortality effect. So steroids, probably yes, for most patients with septic shock. In the last minute and 30 seconds, I'm going to go through angiotensin 2. This too has some biologic plausibility. And the comparators, the catecholamine vasopressors, have their problems that many people have talked about. The Athos 3 trial that others have already mentioned today is the largest and probably the only real trial that one can talk about. Their primary outcome measure was whether or not your blood pressure was higher at 3 hours or the MAP went up by 10. And in fact, it did. At 3 hours, the blood pressure was higher, and you were on lower doses of serum catecholamines. So earlier today, you heard about the problems and the differences between efficacy trials and effectiveness trials. And the study on your left from CHEST is from 5 medical centers looking at what happened in their institutions after the FDA licensed it. And for both those in whom the blood pressure responded, in which the survival was about 40% at 20 days, and in those in whom the blood pressure didn't respond and the survival was under 20% at 28 days, both of them did less well than those enrolled into the trial. Because of that, because of the fact that most of the studies done in other forms of shock have been case series and we did this, the Surviving Sepsis campaign said that we should probably use norepinephrine and not use angiotensin 2, primarily because we haven't studied the safety, because mean arterial pressure at 3 hours is something we can measure, but it's probably not something that our patients care about. And there is a fair amount of data in other agents, and this is true both for septic shock and for cardiogenic shock. Things that raise the blood pressure, like nonspecific nitric oxide synthase inhibitors, don't seem to help patients. So frankly, I don't know who the right patient to give angiotensin 2 is. I rarely use it, and occasionally, if you're on a low dose to modest dose of vasopressors, including norepinephrine and vasopressin, and somebody's feeling frisky, sometimes we'll try it, but it's expensive and we don't know that it works. So I would say most patients don't need it. And with that, I almost made it in the 7 minutes. Thank you very much.
So a big thank you to our speakers, to our panelists, the audience participants. In the interest of time, we're going to wrap this up right now, but thanks everyone, and we'll see you in the next session.